costs and reordered priorities, the state of Oregon has decided to no longer pay for most transplant operations. One much publicized victim of that recent decision was 7-year-old Colby Howard, who needed a bone marrow transplant to fight leukemia. Colby's mother was unemployed and on welfare, and so his final days were spent trying to raise the $100,000 he needed for an operation. By the time he'd raised $60,000, he was too sick to be saved, and he died in December.
It makes your face bigger.
Another potential victim could be Kay Irwin.
And you know where it goes?
Kay Irwin is awaiting a liver transplant and has 6 to 12 months to live. Her employer did not offer health insurance, and so now she must raise the money herself.
I'm sorry.
Kay Irwin's son, Craig, heads the Oregon Transplant Project, an advocates group in Oregon, and good morning.
Good morning.
If this were a year ago, would the state have paid for your mom's operation?
Yes.
Point blank?
Yes.
I know you think the rule's unfair, but since most private insurers, and certainly those we're talking about corporate insurers, don't offer such coverage, why should the state?
Well, that's not entirely true. Many insurance companies in many states across the nation do cover these types of operations, these transplant operations. For example, of the various Medicaid programs nationwide, about 45 states now cover bone marrow transplants and about 40 states cover liver transplants. These operations have become accepted among the medical community and are a very cost-effective way of treating end-stage disease.
Dr. John Kitzhaber is president of the Oregon State Senate, and he was the leader in the decision to redirect state health funds. And good morning, Doctor.
Morning.
Those funds that had been targeted for transplants, where now will they go?
They're being used to extend coverage to a large number of individuals, most of whom are working, that don't have access to either Medicaid or welfare coverage or to private insurance policies.
What's the trade-off here in terms of numbers? How many transplant operations versus how many pregnant women who now will benefit from prenatal care?
Oh, probably the estimate is around 35 people on public assistance who needed transplants versus maybe 1,500 people who are now receiving prenatal care.
What kind of medical input went in this decision?
Well, it was debated in the Ways and Means Subcommittee as part of the overall budget-making process over a number of weeks. I don't know that we had a panel of physicians in making that decision, but it was a conscious priority decision that was made, and it was debated extensively at the Emergency Board a week ago.
Is that your problem with this, Mr. Irwin?
Well, unfortunately, this discussion has been framed that it's a choice between prenatal care and transplants.
You don't think it is?
It's not. The Medicaid program designates that you have to have certain types of procedures and treatments that are mandatory, that are medically necessary, and then there are other optional types of treatment. In Oregon, about 15% of our health care dollar, or about $45 million in the next 2 years, is going to be spent on optional coverage in our Medicaid program for such things as chiropractic and naturopathic care. If the state really has limited resources, we should be using those resources to benefit the people that their lives are on the line.
Well, let me try to frame the policy question. In Oregon, we have people on welfare who have a very good level of health care services, virtually everything that's available to people on private policies, which is as it should be. On the other hand, we have almost 500,000 Oregonians who don't have any health care coverage and are being denied access to even the most basic level of health care services. In that population, we have kids dying for lack of prenatal care. We have kids dying from whooping cough because they can't get an immunization. We've got people dying of heart attacks and strokes because they can't get blood pressure medication. And we felt if we were going to spend more money on health care, that it made more sense to spend those dollars to extend coverage to people who don't have any services as opposed to buying additional services to a small group of people who basically already have fairly good coverage.
A lot of those people do have access to this basic type of care. For example, in Oregon, you cannot be admitted into a public school without proof of immunization. County health departments, for example, do provide a lot of these services. As far as providing basic care to the 400,000 Oregonians that supposedly don't have it, I have seen no proposal or nothing on the table to indicate how we're going to do that. Perhaps we don't have the money to do that, but we do have the money for the transplants.
And let me take a look at alternatives. I mean, assuming that private insurers will not deal with this and those on public assistance cannot get the state to help, what's the answer for those in need of a transplant operation in your state?
There's no question in my mind that by not funding organ transplants, there are individuals who will be affected as individuals. The question is, and the reality is, we're not going to avoid rationing health care in this country. We can't afford to pay for everything for everybody. So we can either choose to allow that rationing to occur by default and be guided by political expediency and very understandable emotionalism, or it can be honest about it and make it on a policy that's guided by some clinical and ethical grounds and take accountability for those actions. And that's what Oregon's coming to grips with, and I hope the country comes to grips with that too.
Mr. Irwin, will you accept that there are limits that all states are going to have to live with, and if your mom's not the victim, somebody else's will be?
Well, one of the points here is that not a lot of discussion went into this decision. What the state policymakers have failed to realize that if you don't pay for the transplants, you're going to have to pay for other very expensive care. And our own medical university has come out with a statement that it might cost as much not to do a heart transplant as to do the heart transplant. The cost of dying is very dear.
What's the best you can say to Mrs. Irwin? I'm sorry.
Well, I think that as a part of a public policy, we've got to take our limited dollars and try to benefit the largest number of people. And I question a policy that says to a working mother, we're going to buy liver transplants for people in public assistance, and we're not going to provide an immunization for your child.
Dr. Kitzhaber, Mr. Irwin. Gentlemen, thank you both. Travel safe.